All right, I got to send her the link. I guess she got the wrong emails or something.
Okay, we're live, everybody. So we're going to start soon as we're going to get started as soon as folks can join us.
Okay.
All right, I think we're going to get started. Welcome, everybody. My name is Karen Rice, and I am the chair of the School of Social Work at Millersville University. And I want to welcome you to our final Policy Advocacy webinar session for this semester. We're going to continue our dialogue around access, and today's topic is access to treatment. This webinar series is part of the Learning Institute at Millersville University. The Learning Institute is dedicated to raising awareness, increasing knowledge, and enhancing skills that lead to the promotion of justice, advocacy, and activism. Our events would not be possible without the dedication of the many faculty, staff, and students across the university. So I would like to extend my sincere appreciation for all of their support. So before we begin, I just want to go over some basic Zoom logistics. Dr. Filizzi is going to be moderating the facilitation with our panelists today. You will have an opportunity to pose questions towards the end of this session, and you can submit those questions in the Q&A box that's located at the bottom of your screen. I also want to let you know that we are live streaming through our Facebook page in order to have a wider access audience reach. So I'd like to introduce our moderator. Dr. Mark Filizzi has earned his MSW from Delaware State University in 1995 and his PhD in social work from Widener University in 2011. He has spent the last 25 years working with and researching children, adolescents, and families, as well as the effects of trauma and the impact of traumatic reactions, in addition to the effects of addictive behavior of adolescents and their families. Dr. Filizzi is a trained provider of this screening, brief intervention, and referral to treatment, SBIRT, substance abuse assessment model. He has examined the effects of violence, family violence, juvenile violence, and the consequences of family instability on youth. Dr. Filizzi has written extensively on these topics, and his findings and opinions have appeared in local and national publications, and he has been interviewed on a number of national radio and television regarding juvenile violence. Dr. Filizzi has joined the Millersville University School of Social Work in 2013, where he is now an associate professor. He teaches advanced human behavior in the social environment, family violence, social work practice, and mental health. He also teaches classes in conjunction with the Master of Science in Emergency Management program in Emergency Mental Health and Trauma. Dr. Filizzi is also the principal investigator for the Millersville University School of Social Work's Federal Opioid Workforce Expansion Program grant. He brings his clinical experiences to life in the classroom and shares his experiences as a therapist with his students. In addition, he has a thriving clinical practice in Wilmington, Delaware, where he works with children, adolescents, and their families. Please introduce to you,
Thank you, Dr. Rose.
Filizzi.
Thank you very much for that. Good afternoon, everybody, and good afternoon to our panelists, and thank you for participating. What I'm going to do is introduce our panelists, and then we'll go into our questions for today, where we will discuss, obviously, the implications of barriers to mental health treatment. I might add that we are expecting another panelist any minute now. She was in a previous meeting. She should be joining us presently. Thank you. So let me introduce our panelist. Anna Kennedy serves as the Executive Director of LOHF, the Lancaster Osteopathic Health Foundation, where she manages the operation, guides the board of directors, leads strategic planning, and oversees communications and external relations, including fundraising and grant writing. Prior to joining LOHF in 2013, Anna was the program officer for schools, recreation, and active living, and evaluation manager for the Pottstown Area Health and Wellness Foundation. Previously, she served as the program officer for the First Five Commission of Orange County in Irvine, California, where she worked to improve the health and education of children ages prenatal through 5. Anna holds a master's degree in urban and regional planning from the University of California, Irvine in the Interdisciplinary School of Social Ecology and a Bachelor of Science in Geography from Penn State University. Anna serves on the board of the Junior League of Lancaster as president-elect this year and the steering committee for the Coalition for the Common Health, a statewide mental health group. She is an active member of the Pennsylvania Health Funders Collaborative, Let's Talk Lancaster, Changing the Conversation About Mental Health, and the Lancaster County ACEs and Resilience Connection Group. She lives in Lancaster with her husband, Stephen Kennedy, and their daughter, Miriam. So welcome, Anna, and thank you for participating.
Thank you. Thank you for having me.
Our other panelist is Vanessa Simmons. She is a licensed professional counselor and registered play therapist. Vanessa holds a Master of Science degree in clinical psychology from Millersville University. Vanessa's professional experience includes providing individual and group therapy at an inpatient psychiatric hospital, facilitating group therapy at a partial hospitalization program, and providing outpatient therapy in community mental health. Vanessa has received specialized training in play therapy, parent-child interaction therapy, trauma-focused cognitive behavioral therapy, and eye movement desensitization and reprocessing. Vanessa recently founded Meadow Grove Counseling, LLC, and provides outpatient therapy to children and adults at her practice in Lancaster, Pennsylvania. So welcome, Vanessa, and thank you for participating as well. Okay, and I do see that we do have our third presenter, Jen DeCola. Jen, if you want to introduce yourself, but I do know that Jen is a graduate of the Millersville University MSW program, and she works with the Community Action Program of Lancaster County. And she was also the director of Bridge House, which is a shelter in Lancaster as well. And Jen, I understand you've also received a new job assignment as well, too.
Hi, thank you, Mark. Yes, Jennifer DeCola. I have been the program coordinator for Bridge House here in Lancaster for the past 3 years and worked with domestic violence services for the past 7 years. And I interned there through my graduate program at Millersville and worked my way through. I recently accepted the position of Assistant Director of Domestic Violence Services in Lancaster.
Congratulations.
Thank you. I also work at Lancaster Behavioral Health Hospital as an admissions counselor, PRN. So that's another one of our areas that we work through. And both of the positions intersect very well, I might add, in some areas so that we're able to balance our services out.
And I might add that Jen also has recently received her licensed clinical social work license in the state of Pennsylvania. So congratulations.
Thank you.
You've had a busy fall. So what I'd like to do now is mention a statement about the current state of the barriers in accessing mental health here in the United States. And then we will have a series of questions for our panelists to respond. Excuse me. Due to the complex nature of psychological disorders, successful mental health treatment often requires regular access to care professionals and a variety of support services. Unfortunately, mental health care services are often not available or are underutilized, even in developed countries. The treatment gap, which is the percentage of individuals who need mental health care but do not receive treatment, ranges from 44 to 70% around the world. And in developing countries alone, the treatment gap can be as high as 90%. 1 in 5 Americans, or 20%, experience a mental illness, with 60 million people affected in a given year. Treatments such as psychotherapy, medication, and care management have shown to improve the health status and functioning of people with mental illness, yet only 43% of people suffering from a mental illness receive any treatment. Today, with the specter of COVID casting a shadow on the world, and especially in the United States, another barrier to mental health treatment has arisen. Since COVID has disrupted daily living, the Center for Disease Control and Prevention recently reported that while emergency room visits have declined during the pandemic, the share of ER visits for child and adolescent mental health patients has risen steadily in the last 9 months. The World Health Organization reported that in the last 2 months, that children and adolescents' mental health has worsened since the pandemic began. The journal Pediatrics reported in October that shortages of psychiatrists and hospital closures have contributed to the rise in children and adolescents' ER visits since the COVID pandemic started in March. And with those remarks, we're not even touching adults and the elderly. Additionally, common barriers to mental health care access include limited availability and affordability of mental health care services, insufficient mental health care policies, lack of education about mental illness, and stigma regarding mental health disorders and the treatment of such. This, in addition to the increased need for mental health services during the pandemic, has taxed and strained and created more barriers within the current mental health system. And with that in mind, the first question I would have for our panel would be, the World Health Organization reported that compounding issues which contribute to barriers for accessing mental health care include both a lack of mental health care professionals at all levels, as well as an increase in medically underserved areas and populations. So I would ask, what steps do we think could be taken now to address these concerns? And I'll put that out to the panel.
I just want to add some statistics that I saw this morning from the Centers for Disease Control and Prevention about the emergency department visits for children. During the first month of the pandemic in March, emergency department visits for mental health usage did decline, but then they've increased steadily since April. And children ages 5 to 11 saw an increase of 24% in emergency department usage compared to the same period in 2019, the previous year. And for children ages 12 to 17, that was even higher at 31% increase. And this is for mental health needs. So that is definitely concerning. And some of the research is indicating that social isolation and remote learning, so lack of access to mental health services that were previously provided in school settings, is definitely contributing to that increase in emergency department visits. One of the things that we are particularly interested in looking at in Lancaster County in my work is really increasing the workforce in mental health. And so we're looking at, the supply and demand in mental health, and really trying to increase the supply of licensed mental health providers in Lancaster County. And so we're looking at this talent pipeline of students that are graduating with their bachelor's and master's degrees in fields like social work and psychology that could lead to a clinical license in mental health, such as therapy, counseling, social work, those fields. And what we found is that there's really a gap for the mental health careers. That pathway is not as strong as it is in medicine. So for somebody who wants to become a psychiatrist, the pathway is much more linear. They go through medical school and complete a residency and do some additional work in psychiatry and become a licensed psychiatrist. Even in nursing, that pathway is a little bit more linear, and a nurse could become a psychiatric nurse practitioner. But in mental health, it's a little bit more of a circuitous pathway. And master's level graduates in social work and psychology need to complete clinical supervision of 2,000 to 3,000 hours. And both of you know this, but so that is a barrier for many students who are graduating to get their clinical supervision hours before they can become licensed in Pennsylvania. So we've created a collaborative where we are funding 8 behavioral health practices this year, and for 3 years, really to help support and alleviate the expense and on the students and also the providers to provide that clinical supervision. So in 3 years, we hope to have 30 new licensed therapists and counselors practicing in Lancaster County, to really help alleviate that shortage of providers that are licensed caring for children and families in our community.
Anna, that's wonderful to hear. Just because I know how tough it can be to receive those supervision hours. And part of it is, when I thought about this question, I thought, well, it would be great to increase funding and access to education for, master's and doctorate programs, but also having that extra support when you're working towards your license, because you have to have a certain number of clinical hours in addition to getting the supervision, and not all employers are able to provide that piece, the supervision piece. So that can add another financial strain to individuals who typically receive a lower pay because they're not fully licensed yet.
Yeah, Anna, that's absolutely an outstanding program. I also would advocate at this time to increase funding in the pandemic funding, because what we're seeing in healthcare is a byproduct of the pandemic. So we're seeing that increase in the healthcare, increase in isolation, increase in the depression and suicidal ideation, and so much in adolescents who are really missing out on some of those developmental years and their relationships with others. So absolutely, advocacy for increasing funding. That is so much of where it starts to have those services available.
And what's interesting about this is that I have many students who graduate with their MSW and they'll say to me, what do I do next? And you had all alluded to the fact that it's not a linear process. You make phone calls. Who do you know who can provide supervision? And now we look at this increasing need for mental health services, yet we don't have those clinicians that can fill those gaps. However, they want to fill those gaps, but they don't have the wherewithal or the process in many other areas. And fortunately, Lancaster County, we have that ability now with LOHF creating the fellowship. So that's a step in the right direction. In many low and middle income areas, the high cost of psychiatric treatment, often due to high copays for insurance, high medication prices, inaccessibility, inability to access treatment, pose significant financial barriers also to patient care. In addition, these copays and trying to sign up for insurance and out-of-pocket expenses can also make mental health care unaffordable for many people. Are there methods or practices that we could adopt to address this high cost of care? And all of you are practitioners, all of you are working in the field. And so the question would be, what can we do out there to make the cost, I don't know if I'm going to say more affordable, but more palatable for people to access care?
I mean, like many kinds of healthcare, the more that we can do to identify symptoms early and prevent a crisis from occurring in the first place. So preventing those emergency department visits with therapy and counseling, access to mental health care sooner, so that, a child, adolescent, family, parent is in treatment to learn coping strategies and be able to, be healthier in the long run. We're going to decrease overall costs in healthcare by decreasing the prevalence of crises and use of the emergency department. So, I mean, in our work, again, at LOHF, one of the things that we've done in recent years is we have a copay assistance program for mental health care that's really designed to help families who meet certain income qualifications. They can apply and participate in the program, and then they only pay $10 per visit to see their therapist. And what we found in this program is that most patients, patients can apply directly, but most patients are actually referred by their therapist or counselor because they disclose that they're going to delay or end their current treatment plan early because the high cost of copays. Copays can be as high as $50, $60 per visit on commercial insurance. I mean, insurance affordability is a whole other topic we could talk about, but with commercial insurance, the high cost of copays might mean that patients are just not completing treatment plans as recommended. So we found that more patients are adhering to those treatment plans and completing their therapy and counseling visits because they don't have to pay the high cost. So that's definitely been a good thing. We would love to see more people participate in that program, and increasing the eligibility for incomes is something that we're definitely looking at. I think the other thing that we've seen through the start of the pandemic is really the prevalence now with telehealth and teletherapy becoming more utilized, and that has, in some cases, decreased the cost for some patients. But yeah, Lancaster County in particular has a pretty high uninsured rate for families and especially children. So efforts to just help people apply for and keep their health insurance is a great first step in trying to, children are eligible for the CHIP, Children's Health Insurance Program, and many children are also eligible for Medicaid, but unfortunately families, things come up and they let it lapse. And so that's something that I think we as a community could be addressing.
There's also a gap in our community, I believe, too, that I don't know what the solution to that gap is. We need to have a triage place at some sort where we're seeing clients who have lapsed in their medication and are unable to get an appointment in enough time to get that medication refilled. And then they end up in our ERs, they end up in our acute psychiatric facilities. And unfortunately, if they were able to get that medication, even if they did miss their psychiatric appointment, even if they, because this happens when somebody is in crisis, and we know that if there was the ability to get those medications refilled in a timely manner, other than prior to having to go inpatient, or without having, the only way to get that done is to be inpatient because your psychiatric appointment is 6 months out. So, and as we all know in mental health, that's a spiraling effect, that depression and despair and all those things, just they bottleneck, and the next thing you know, we're inpatient, we're doing, a 7, 10, 15-day inpatient stay, when if they had the ability to get that medication in the emergency, that or in that interim, that they might not have had to have that lengthy stay, or could have stayed out in the community. And that has that effect further down the road. They might have been working when they came in, they might have had stable housing, and then because of that 15-day lapse that they might be inpatient, it has the domino effect the whole way down. So if we had something in place that we could do that, that very quick fix, it's a Band-Aid in the system, but it's a huge piece that causes so much more cost in the system. If we had the ability to do that, walk in somewhere to get those medications,
Sort of like a one-stop shop.
it would be great.
Yeah.
But even something that just to bridge the gap, there's so many clients, and I've worked with so many people, and especially during the pandemic, who have missed appointments, didn't want to go out, weren't able to get their refill. It's Friday and their prescription won't be refilled now until Monday, or something in that nature, that they have nobody to contact in the middle. So if we had something in the middle where somebody could get the help that they need quickly. And unfortunately for psychiatric medication, it's not something that a lot of family doctors won't order it anymore, or many of our clients don't have a primary care physician. So we're helping with, trying to support all those areas, but that's something that we see often with that gap.
That's interesting, and not to take anything away from a primary care physician, but they're not trained.
Right.
The rotations they do in their residency might be 2 weeks in psychiatry.
Right.
And we also know that there are emerging medications. And they may just not have the experience, but we understand that a lot of our clients do rely on the PCPs.
Mhm.
Yes, it's often the first place that families will go is their primary care provider. Yeah.
What I found helpful is to collaborate with providers and try to be preventative about this, although it's not always possible because typically individuals experience a higher level of stress which affects their ability to sometimes problem solve or think ahead as well. But I also work for community services group, and one of the things I really appreciate is being able to collaborate with the case managers and the prescribing providers to just stay in touch about clients and discuss any needs that they have and advocating for them. It's so important to do that to hopefully prevent some of those concerns that lead to hospitalization. But it's not always possible, unfortunately.
Yeah,
You
there
know,
is.
Go ahead, Ed. I'm sorry.
There's
Go ahead.
a model that the Medical Directors Institute from the National Council on Behavioral Health has promoted a coordinated care or collaborative care model. Vanessa, it's what you were just describing, where the psychiatrist, who's typically the medical director, is available to provide basically like a case consultation to primary care providers, to case managers, and other mental health providers in a team approach, so that because there's a shortage of psychiatrists, they're able to then really collaborate and provide consultation to the whole team, so that their time can be more triaged to the what Jennifer is saying about the medication management and review consultation with the rest of the providers on the team. And that those approaches are really trying to help support the whole team together, to really encourage best practices for patients.
Mhm.
Not ideal, but it's the reality of shortages that we're experiencing.
I had the opportunity yesterday to speak with a psychiatric nurse practitioner about a client whom I referred to him. And, I got off the phone call and 10-minute phone call talking about the client, talking about the client's needs, the client's the assessment of the client. And I thought, man, this is wonderful. This is really wonderful because it's going to help me with treatment planning. It's going to help the client ultimately. And then I kind of got a little depressed because I said, I wish this happened more often because this is what a great model. This just communication and collaboration. It's amazing how far it can go to lessen a lot of the burdens on the client. And also, and also make treatment obviously more accessible for people. Okay. Another question. The World Health Organization cites a global lack of comprehensive mental health policies, which are crucial for implementing and coordinating mental health care services. Nearly 1/3 of all countries and almost half of all African nations have no comprehensive mental health care policy or plan. Among countries with mental health care policies in place, about 40% have not been revised since 1990, and that's 30 years, and do not address recent developments in mental health care. In many low and middle income areas, as well as rural communities, the localization of mental health care resources in large population zones or cities has been cited as a key barrier to providing mental health care to the entire population. And geographical decentralization has been recommended to improve accessibility to mental health care in non-urban communities. How can we respond to that? Or what can we think about? What can we envision to address those areas that are not being served? And I certainly understand the resistance for those who do not live near a city to come into a city or to come into a dense population area for services. So what can we do to address those issues?
Well, one thing that I guess one good thing that came out of COVID was implementing telehealth, which surprisingly, well, not surprisingly, but which provided individuals who typically are not able to have access to mental health services. They're able to receive those through mental health, either by telephone or by video. And oftentimes, working community mental health, Some of the barriers include transportation issues or having issues with paying copays. And so fortunately, some of the insurances have covered or waived copays, which has been really helpful. So I'm hoping that this will be something that we can continue to use for individuals who are not able to make it to their appointments in person or who just don't feel comfortable coming in person.
Thanks, Vanessa. Yeah, I agree completely. In early early summer, I worked with the Pennsylvania Office of Mental Health and Substance Abuse Services to complete a survey of mental health providers in Pennsylvania about their use and feelings about telehealth in Pennsylvania. And what we found was that providers were generally very pleased with it, happy to continue using it, wanting the assurance to know that it's going to be reimbursable, continued past a month or two. They wanted longer term assurances, and that it's effective. For providers want that to be able to use their own judgment to determine when a patient might need to be seen in the office and when it's appropriate to use telehealth services. But by and large, we saw great feedback and encouraging the continued use of telehealth services. And I think for patients too, it really does increase their access. It removes barriers, even barriers like childcare or like you said, transportation, or even before the COVID pandemic, we were seeing the use of telehealth to reach more rural communities. So patients could, prior to COVID, patients could go into a mental health provider's office and connect through telehealth to a provider at another location. And that was expanding access to care for patients that may not have been able to see a psychiatrist in particular, or even play therapy. I mean, there's all kinds of ways that we can expand access through telehealth services. So I hope that continues.
Very excited that in case it will snow out there, we can still keep our appointments.
Yes.
Mark, we had some questions in the chat too. Did you want to?
Yeah, what we're going to do, Jen, is we're going to get to them in a few minutes. We were going to just address them in a few minutes.
I also want to add, and this it's back to the question about improving access, is in October, Governor Wolf announced a new healthcare proposal called Whole Person Healthcare. And it really is aimed at improving affordability outcomes and also to tackle the health inequities resulting from systemic racism in healthcare. And it's very exciting. This advocacy work on whole person healthcare has been going on for several years now. And what this does is it creates an interagency health reform council. So really starting to see departments throughout Pennsylvania work more collaboratively between Department of Health and Department of Human Services in particular. And it also creates regional accountable health councils. So that's promising. It doesn't tackle everything that we'd like it to do, but it definitely is a step in the right direction. The other thing that I think is really important here is federally qualified health clinics, the FQHCs, are crucial to serving underserved populations, especially the medically. They're designed to help increase access for medically underserved areas throughout the whole country. So we have 2 in Lancaster County. They recently announced that they're merging, which is also exciting. I think it increases our reach throughout all of Lancaster County. And it's important that we continue funding and supporting these health clinics. We also need to make sure that rural hospitals stay open. They're often the main providers of healthcare in rural communities throughout Pennsylvania and across the country. So that is very important. And we hope that the federally qualified health clinics and rural hospitals will continue to be able to serve our populations. those populations are definitely in need, often highest need for healthcare.
Yeah, that's good to hear about telehealth, because, you know, we do hear that it's difficult at times, but I'm really gratified to hear that. And I think about, you know, 20 years ago, I was working in Dover, Delaware, and I remember speaking to a mother, and I said, you know, it's important that you get in to make this appointment tomorrow to meet with a psychiatrist, because we want to get your son the treatment that he needs. And she said, Mark, I have $10 to my name till next week, and I have to feed my children. So do I put gas in the car and drive all the way to Dover to see you, or do I make sure my children are fed? And that hit me pretty hard. And, you know, 20 years ago, had we had telehealth, we wouldn't be having this conversation now. So I see that as a positive, especially in areas that don't have the access or don't have the ability to access treatment. So we're going to take questions after. We're going to have one more question, then we're going to take questions from the Q&A here. So I want to talk a little bit about stigma itself. And numerous studies have found that the stigma associated with mental health often prevents patients from seeking and adhering to treatment, as patients may attempt to distance themselves from those labels that often occur with mental health treatment. Additionally, many cultural beliefs may not recognize mental health conditions or the need for treatment of such. So how can we, I guess, up our game in educating the majority of our citizens to expand educational mental health treatment? And probably as an add-on to that, do we see a shift in our society where that stigma we're starting to chip away at that stigma? And I just wanted to get everybody's thoughts on that.
I think we're starting to see some among children and adolescents, the stigma is really starting to decrease, which is good. Among adults, not quite so much, but it's moving a little bit. And I think the COVID pandemic has really kind of brought it to a forefront for many people. And people are, you know, talking about mental health a little bit more than we did previously. One of I think some of the most promising solutions around education and reducing stigma is the universal screening programs. So there are programs in Lancaster County. One is called Teen Hope that will, when we were in school in person, they were screening all children in grades 6, 8, 10, 12, etc. And doing depression, anxiety, and suicide risk screenings. And it's an opt-out program. So most of the children, most families would agree to the screening program. And it's very successful because it identified the inward acting children who may not outwardly display any concerns about mental health. They're not disruptive in the classroom. They're, just quietly suffering, but they're responding to a screening tool that identifies that they are indeed at risk. So I think those kinds of screening programs are very effective, especially when they're linked to a referral for treatment right away. And that, I think, is what makes many of those programs effective, is that when a risk is identified, they're debriefing right away with the student, calling the parent and talking about the result of this screening tool. Another great resource that's available to everybody is mental health first aid training. And I just would really recommend and support people going through mental health first aid training. It's a phenomenal one-day sort of broad scope lay of the land in terms of, what are symptoms, what are signs, what do you do about it, how do you have a conversation with somebody until help arrives, like a CPR for mental health. So definitely recommend that.
Vanessa, do you want to add to that, or?
So what I've noticed over the last couple of years, local PCPs or offices have added clinicians to their team, where they work in those offices And so there has been an increase of referrals from those clinicians who are able to support the families for short term and then refer them for long-term treatment if they think that would be beneficial. So I think that allowed individuals to receive services when they may typically would not have received services. Another thing I would like to see is an increase of providing education to schools and maybe increasing our presence there, although there are school counselors and clinicians who work at schools, but that would be something wonderful just to increase awareness. And part of my approach is always including parents in the treatment and just increasing awareness of the expression of psychological disorders, just to increase the support at home and have a better understanding of ways to support their children, which is so helpful and sometimes I think may even increase awareness within themselves too. So I think, we're just plant seeds and I hope that it will spread out further and further.
I will say anecdotally, in my own practice and in working with my students is, the stigma that we saw that was so pervasive 10, 20 years ago is starting to erode, which is good. And you talk to high school students who don't really see any sort of stigma with receiving help or obtaining help. So I think that's a positive. That's a step in the right direction as well too. I always think about smoking, and 60 years ago, smoking was okay. And here we are today, and smoking is really not considered something that is almost socially acceptable in a lot of ways. So that took time, but it was one of those changes that really took hold because of education and information being disseminated. I want to take time now to look at some of the questions the audience has posed for us, and we have a few in the queue. So let me get to them right now. So one of the questions we have is, do you feel that the funding for mental health care, especially providing incomes for already underpaid workers, parenthetically social workers, clinical psychologists, should that funding come from state or federal funding or some other source? Any thoughts?
So it's actually a blended funding model. So in Lancaster County, funding comes from Pennsylvania, and some of that is federal funding. Some of the federal funding requires state funding matches, and then some funding is county dollars, but very, very little. It was over 10 years ago that there were cuts made to mental health and behavioral health services at about 10%, and those cuts have never been restored. So the services really are underfunded at a federal and state level. Counties often don't, they do contribute some portion, and they have some authority about how those funds are allocated. But until recently, the formulas were pretty strict in terms of how the funds had to be allocated. And that's primarily the Medicaid population. For commercial insurance, it's a little bit different, but it is definitely still an underfunded service for sure. I don't know.
I always think of, my students say, I'll say to my students after they graduate, so where are you working? Well, I'm working at 3 places.
Yeah.
And that's not uncommon. And I understand people are consulting, they're working for an agency here, they have a private practice here. It's never just one, unless they're in administration or something along those lines. So I find, given the fact that we don't have that, we need practitioners, those people are stretched thin and they're underpaid at their main job. So anything we can do to support them. One of the other questions we have is, Pennsylvania is completing its rollout managed Medicare plans. How does managed Medicare affect access?
It's a good question. I mean, my work is mostly with children and adolescents. So Medicare is older adults. So I know the long-term services and supports systems are being rolled out, and it does also, so it includes services for children and adolescents who've suffered like a traumatic brain injury, or so occasionally there are overlaps with families and children and adolescents, but by and large, that's the older adult population. I will say though that many providers have told me that commercial insurance plans tend to follow the guidelines of what Medicare authorizes. So in some cases, it is really helpful to know what Medicare is authorizing, because they tend to set the standard or some of the guidelines that other commercial plans will then follow. I don't know how accurate that is for sure, but that's what I've heard.
Yeah.
Well, one of the limitations right now with Medicare is that only LCSWs and people with their doctorate, individuals with their doctorates, are able to provide services to individuals with Medicare. So as an LPC, I'm not permitted to support those individuals. So I would like to see a change for that, because I do think that affects access for services, for sure.
And on the Medicaid side, back to the first question about licensing, unlicensed but clinically supervised master's graduates can only see Medicaid patients. They can't see and bill for commercial insurance. So, in my experience, then that doesn't completely train the unlicensed person to the full scope of patients that they may see then when they are licensed. It's sort of limited their scope of practice. So
That always sounded counterintuitive to me.
yes, it does. It does really. I think it has something to do with the agencies that are authorized, that are billing Medicaid, but it doesn't make a whole lot of sense to me either.
I've worked in a number of states where the states would have a program and they say, well, if you have an MSW, that's fine. You don't need an LCSW. And I would say, wow, these are some really involved cases. I think someone with an extra level of training might be indicated here, but that's not always the case.
Right. They tend to be more complex needs.
Yeah. And accessing several services at once. Yeah. There's an interesting question here, and it's one that I would actually like to know and have tried to answer for some of my students, and really haven't found much information. But are there statistics for patients who want telehealth versus in-person care? And the questioner is curious because they were working to help a student find a counselor willing to meet in person, and it was very difficult, obviously in times of COVID. This student wanted in person, so roommates couldn't hear sessions, and because they so desperately needed face-to-face interaction, which was contributing greatly to their depression. So.
It's a great question.
Boy.
Yeah. And I've heard that the use of the text services has increased during the pandemic as well. And if Jennifer was here, I'm sure she would also comment on this regarding domestic violence, that the silent, ability to text, like the crisis text line, for example, is a great resource. The ability to text is silent, so other people in the household aren't overhearing the conversation. Back to the study I mentioned earlier with the Office of Mental Health and Substance Abuse Services, the study also included consumers and patients. So there are data now for Pennsylvania about consumer and family use and preferences around telehealth. And I can certainly pull that and share that with you. But it's really, it's a decision between the practitioner, the provider, and the patient. And they both have to agree that in-person care. So I would say, based on that, there are providers who are seeing patients in person. It just might be, a little bit of a few extra steps to find, a provider who's willing to see patients in person, but they do exist. They are happening. And for a situation like that, I think it probably warrants an in-person visit.
Mhm.
Vanessa, I don't know if you.
What are you seeing in your practice, Vanessa?
Well, what has been helpful is that with telehealth, you can be flexible. So some individuals who appear to benefit from telehealth, but they don't prefer, for whatever reason, participating in sessions in their home. As long as we're aware of their location, they could, for instance, although that's not ideal, they could, for instance, participate in session in their car or somewhere where they would still have a sense of safety. And this is not for everyone, of course, but it's a way to participate in telehealth by possibly using their phone to connect to the session or by talking on the phone. Some insurances approve that. That might not be ideal, but even just exploring other options is sometimes really helpful, knowing that this is temporary, hopefully.
Yeah, there are, I know in my practice, there are, well, most of my clients, I do in person, although I'm in Delaware and the governor has just stated that, stay-at-home orders and all that. And although for some reason I'm considered an essential provider, but then again, it's for some reason my clients are not fond of telehealth. However, I know other clinicians who clients have just taken to this like a duck to water. I do know that, and I know one of the cases that I have when I asked him about, and he's a young man. I asked him, I said, well, what is it about telehealth you don't like? He says, my mom's listening in the other room. Because it's a custody situation, one of those things. And that really got me to thinking about, how can we as providers, secure that confidentiality. But Vanessa, you made a good point. If we can do it on the phone, they can go to the park or they can take a walk or whatever, something along those lines. So we can offer some options with that. So I personally, as a practitioner, I'm grudgingly coming around to it. But I can see why clients enjoy it, and I can see why clients are a little reluctant to use it as well too. Here's a question. Okay, we've got a couple of questions here. Anna mentioned that telehealth services like BetterHelp and Talkspace, which offer text-based counseling, have been on the rise. But I wonder if there's any research that this more accessible mode of treatment is really effective without any face-to-face interaction, especially if it's been using for longer-term counseling and not just crisis management. So what are your opinions on that? If we say this, knock on wood, this pandemic's going to keep us on telehealth for the next 6 months, what do you think about the effectiveness for long-term care versus short-term acute care with telehealth?
The telehealth services, like I mentioned, the crisis text line, they're not a replacement for therapy or counseling. It's really meant to be a like a stopgap measure to be really temporary, and it's effective when it's linked back to local resources and referrals are made based on the acute level of need for the patient. I think they're effective sometimes because they're available 24/7. So if a patient is experiencing an episode or something in their safety plan, they can't reach the caregivers and on their team, or it's a crisis kind of situation, or just needing to talk to somebody, or texting back and forth in the middle of the night, it can be helpful for those instances, but it does not replace a full therapy or counseling session at all. I think it can be a component, like a tool in the toolbox of the rest of the full scope of care, but it's not a replacement at all.
And that's what you think.
I don't have any experience with BetterHelp or Talkspace. I tried looking into it, but I couldn't find too much information. And I do wonder how the services that they offer, how that is affecting individuals and how effective they are. I think some individuals prefer using texting versus talking to someone or being visible. But yeah, I wonder if that could be done long term. I don't know.
Yeah, yeah. And it's, again, we're taking, in essence, we're increasing access, yet we're taking the human component out of it. So it kind of comes with its own set of issues. So we're at 12:55, and I want to thank our panelists for participating. Of course, thank members of the audience. And Dr. Rice is going to wrap up for us, if you will. So thank you again, everyone. I appreciate your time and your effort that you put forth today. And now I'm going to turn it over to Dr. Rice. Thank you.
Thank you, Dr. Felici, and thank you to our panelists. This has been extremely informative and engaging for me, because Millersville is hoping to enhance, various aspects of both psychology and social work programs to ensure that we are preparing, right, our students for work in this important area. Just to wrap things up for those of you attending, we do appreciate your feedback. It helps inform future webinars that we host. And so you're going to get an email probably later today from our grad assistant, Shana Landis, who will send out an email sharing the link to complete a short survey. We do hope that you complete it. Again, it does give us feedback on how to both enhance future webinars, but also topic ideas. Just to let you know, next semester, we're going to continue with the theme of access, and she will share with you the topics and the dates so that you can save the dates for next semester, as well as other future events. But because our goal with the Learning Institute is about advocacy and activism, she will also share with you ways to get involved, what you can do to respond and help us ensure that individuals within our communities, whatever community we reside, have access to these resources and services that we need. So again, thank you very much. Stay safe. Happy holidays to everybody, and take care.
Thank you.
Thank you.
Thank you.